Good evening and welcome, everyone. We're excited to have you join us for this webinar brought to you by Apex Biologics with Dr. Marc Gruner on achieving the highest percentage of responders for autologous orthobiologic conditions and pain management. My name is Lauren Darren, and I will be moderating tonight's session. Thank you so much for being here. We want you to know that your participation adds great value to this session, so please feel free to engage with questions via the chat feature in the Q&A section. It is a great honor to have Dr. Marc Gruner with us today. I'm going to make a brief introduction to him, then turn things over to his lecture. Dr. Marc Gruner is an interventional sports medicine physician at Bethesda and Washington Sports Medicine Institute. He is affiliated with Johns Hopkins University and is the founder of Limber Health. He completed his fellowship with the leading experts in ultrasound and regenerative medicine at Mayo Clinic, residency at Georgetown, and a medical degree and MBA at Virginia Tech. He is passionate about value-based care and regenerative medicine and extends his teaching to ultrasound learning at a national level. With that said, we're going to turn things over to Dr. Marc Gruner.
Thank you, Lauren. Appreciate it. Well, I look forward to touching base with you guys tonight and going over something near and dear to my heart. The evidence of regenerative medicine for orthopedic conditions. We'll reserve questions for the end. Here we go. All right, so I do have a disclosure to discuss. I am the co-founder of Limber Health, a remote therapeutic monitoring platform that helps with regenerative medicine protocols and also help Tempeda out. Tonight's agenda, we're going to focus on the science of PRP. We're going to go over the evidence of platelet-rich plasma. We're going to go over arthritis, tendonopathy, evidence of stem cells, some consensus studies that I think every doctor should know about, selling honest expectations. We'll go over an elbow case study. We'll discuss, if we can put the whole package together, what does registry data look like for some of the patients that I see in the clinic, and then some take-home points on diagnostic ultrasound. So the first thing, when anyone hears about orthobiologics, they think it's the Wild Wild West. You got some people who say this is the best thing since sliced bread, and other people who says that there are a lot of people that are crazy and it doesn't even work. And I hope after this conversation, I can go over the evidence and really explain what's the honest truth about regenerative medicine. So as you can see in this X-ray, we have normal arthritis and we have severe arthritis. And between physical therapy and surgery, most of that being a hip replacement or a knee replacement, there's a lot of treatments in between. And regenerative medicine is something that I think can really help a lot of people hopefully avoid that knee or hip replacement and hopefully prolong the need for other services. So what happens if the knee replacement gets done too early or is inappropriate? Well, this is an article in the Washington Post that showed that 1/3 of patients with a knee replacement are unhappy and dissatisfied with their care. And I think part of that is that sometimes we're doing the surgery too early. While hip replacements do well, knee replacements still need some improvement. And I really think that one big role for regenerative medicine is focused on how can we try to identify the right people for knee replacements later on down the road. And in addition to identifying these people, there are machine learning studies where they're trying to look at registry data and try to predict who's going to be a responder or non-responder. And one of the things that I'm hoping to accomplish using technology is trying to do the same thing for orthobiologics and hopefully being a partner for a patient along the continuum of their care. So tonight we're going to talk about non-operative regenerative medicine. And the first two things that we'll talk about is PRP and autologous stem cells. The majority of the talk will be about platelet-rich plasma. So platelet-rich plasma is where we take your blood, hopefully if you're getting an adequate dose, at least 60 cc's, and then we take that blood and put it through a centrifuge, and then we break it down into the plasma, the platelets, and the red blood cells. And the buffy coat is where a lot of the platelets live. And what's really key is getting an adequate concentration of those platelets. And the way we do that is through a benchtop press to extract the platelet core plasma and make sure that we get that buffy coat of platelets. And so PRP is being used for many conditions. People use it for baldness, people are using it for arthritis, people are using it for tendonitis, people are using it for ligament injuries and muscle injuries. Tonight I'll go over the evidence mostly for arthritis and tendinopathy where we use it the most. And a lot of patients come and see me and they ask, what's the science of PRP? And the way I explain it is arthritis is caused by markers of inflammation, and it causes cartilage to break down. And the PRP adds growth factors to the joints or to a tendon to stimulate long-term healing. What's really, really important, and I think that's different than steroids, which we use a lot in the clinic, is that PRP is very safe because it's used your own body's platelets. Allergic reaction is unlikely. So those growth factors, so those platelets secrete these growth factors, and there's many different growth factors that have different processes. And I won't go through all of them tonight here in this chart, but what's really important is that they do 3 different things. And the way I explain it to patients is that this does not regrow cartilage. And I think one of the important things about an honest expectation is telling them exactly how it works, so they really have a good idea of what the effect is going to cause from that. And so on the left here in picture A, you can see that the first action of PRP is it inhibits the NKFB pathway, which works at the transcription level that reduces these cytokines, which are IL-1, IL-6, MM13, and COX-2, which cause inflammation. The second thing that it does is it brings blood supply. And we know when we bring blood supply, that can help healing, whether it's a meniscus, whether it's the cartilage, whether it's a tendon. Anytime we can bring blood supply, that is one thing that can help with healing. And then the third thing, although it doesn't grow cartilage, it does help the cartilage be protective. And the way it works in this pathway is by augmentation of the bringing in new collagen for tendons, and then also for the atom going through MM13 and inhibiting the MM13 pathway. So just to sum it up, the way I explain it to patients is platelets decrease inflammation, they bring blood flow, and they help be cartilage protective for a joint and help with tenocytes, the tendons grow. But it's not just about the platelets that are important. We talked about the dosage is important. I think studies have really come out. This is a study that just came out this year that I want to make sure everyone is aware about. And although you'll see some studies that have used low concentrations of platelets, this is a prospective, triple-blind, randomized controlled trial published in the American Journal of Sports Medicine. And it showed that a higher concentration of platelets, so 7 to 10 times the concentration of platelets, has a significant improvement in an outcome for a patient than a low dose of platelets. So when I'm thinking about an appropriate amount of PRP, just like taking the appropriate amount of Tylenol or the appropriate amount of ibuprofen, you want to make sure you have the correct volume and dosage for your platelets. But it not only stops there with the actual amount of platelets that you get. Those platelets change with what you eat. Your nutrition is a really important factor. The second thing that's an important factor is your demographics. So if you can see in this picture, younger people have a lot more platelets than older patients. So one thing to think about is, do we need more platelets for older patients than younger patients? And your BMI and the type of, and your sex all play a role into your platelet count. And when it gets really challenging, when someone has a recurrent effusion, that's when I start thinking about A2M. Although there aren't a lot of randomized control studies yet, I do think A2M is a really interesting protein concentrate that we get from the plasma that has the ability to help with decreasing inflammation, specifically in the joint. And so I'm going to just highlight how that works. So A2M is found in the blood plasma after we've gotten the PRP. And essentially what it does is it's a protease inhibitor where it can actually engulf these cytokines. And it has really potent anti-inflammatory process. So one of the things that the way PRP works, as you saw on the last slide, is it increases inflammation. And so by increasing inflammation, it usually, the way I counsel patients, it's going to be 3 days after the procedure. But one thing about the A2M is that because it can act quickly on decreasing the inflammation, it has an effect to not cause as much inflammation during that acute inflammatory period, which I think is helpful for patients that need to recover more quickly. And as you can see here, I mentioned it's a broad spectrum protease inhibitor. And so what it does, in the picture on the right, in the cartilage of the joint, you can see that it engulfs these three cytokines. And those cytokines are TNF-alpha, IL-1, and IL-6. And by doing that, it can actually remove the inflammation pretty quickly within the joint. And that's why I think it can help with an effusion, especially someone who's having recurrent effusions or is a non-responder to PRP. Secondly, because the protein concentrate is a little more viscous, I find it interesting as a scaffold for partial tendon tears. And in addition to actually looking in a joint and actually removing some of the cytokines within the joint synovial fluid, it also has an effect on the cartilage cells and also on the bone cells. And I think these are things that were really interesting about A2M, that there's more and more studies that are going to be coming about in the future. So we're going to move away from the science and we're going to talk about the evidence of PRP. And I think these are studies I'm hoping to arm you guys when you're going to a commercial insurer, when you're trying to talk to a patient about what's the evidence. I practice in Bethesda, Maryland, where I live right next to NIH, and every patient is, it's an affluent community, and every patient is, I wouldn't say every patient, but there are a lot of patients that are physicians or scientists, and they'll always ask about studies. So I hope you'll see that there's a lot of studies out there. I've made sure to include a lot of the ones that I think are more interesting for doctors to know about. So the first one looked at the efficacy of PRP for the treatment of knee arthritis. They took a meta-analysis of level 1 randomized control studies and showed strong improvements in pain and function compared to the control group. The second one also looked at level 1 and level 2 studies, and they compared it to hyaluronic acid. And these were two large meta-analyses that looked at level 1 randomized control studies and showed significant improvement in pain and function that last at least a year. So the way I explain it to patients, and I'll show you a few more studies, is that if you've got mild to moderate arthritis, you've got a 90% success rate of improving your pain and function for at least a year. As you work down to moderate and severe arthritis, that number can drop. And there's different percentages that I've been really interested in quoting for patients. And that's something I'm doing with my registry that I have in my clinic. So this is these are two other studies that looked at level 1 randomized control studies published in reputable journals. And the one on the bottom right here looked at PRP, and it answered an important question a lot of patients ask: does PRP delay the need for a knee replacement? And this looked at studies, and they showed that one injection of PRP delayed the need for a knee replacement by 5 years. In my patients are coming back now, and some of the PRP is wearing off. And I've noticed that it's usually about 3 years on average that patients can get improvement, but the studies have shown at least 1 year. And in addition to those single-blind randomized control studies, the Journal of Medicine Baltimore in the state of Maryland published a journal article that showed PRP versus HA, and it was a systematic review and meta-analysis of double-blind randomized control studies. And the PRP was more effective for improving pain and function in those patients than the hyaluronic acid. So this is a study, so I trained at Mayo Clinic, and the chair of orthopedics at Mayo Clinic published this study recently. This is hot off the press, and it was looked at PRP versus alternative injections for osteoarthritis. And the conclusions from this study showed that PRP had a significant advantage over hyaluronic acid, improved pain symptom relief, lower rates of a reintervention, and more frequent achievement of the MCID, the minimal clinical important difference for pain and function. And so I think this is one study that I think everyone should know about that just came out this year. So now we have all these level 1 randomized control studies showing that PRP is more effective for knee osteoarthritis than other treatment options. And so Brian Cole at the University of Chicago he took all the level 1 randomized control studies, and he said, what is the quality of life improvement for a patient if PRP lasts at least 12 months? And the cost to society and what that benefit would be, and that was about $1,200. So the average PRP cost that a doctor might charge is around $800. But I think that if you're anywhere between that $1,200 range and that PRP lasts at least a year, you're providing a quality of life that's measurable. And I think these are the type of studies that will help with commercial reimbursement. So now we'll move away from arthritis. We're going to talk about tendinopathy. The first study came out from Stanford University in 2014. It was a double-blind, multi-center, randomized control study. And they looked at 230 patients. And they looked at the difference between PRP versus the needling alone. And they showed no difference at the short-term time frame, but they showed a significant improvement in PRP at the 24-week process. And I think that's really important because in my practice, I'll see PRP be more effective between week 3 and week 6. So I always tell patients they're going to have more pain for those 3 days. And then between week 3 and week 6, then they're going to see some improvement in their pain. And then it'll get better each week up to a year. This was a study that was done out of Emory University, and it compared PRP versus 10x for the treatment of golfer's elbow or tennis elbow. And it showed equal outcomes, and both treatments had great outcomes for improvement in their pain and function. The next 2 studies that I want to talk about are leukocyte-rich PRP for the treatment of gluteus medius and minimus tendinopathy. This is a study that I usually will give the patients. It was done in Australia. It was a double-blind randomized control study with 2-year follow-up, and this showed a significant improvement in pain and function over the course of those 2 years for glute tendinopathy. The second one, and I get this question asked a lot, how does PRP compare to surgery? Well, this was a study done out of Tulane University in New Orleans. It showed PRP is equal as an alternative to surgery for golfer's elbow. This was a randomized double-blind control study showing that the high volume injection, PRP, was more effective than the sham treatment for mid-portion Achilles tendinopathy. And I think there still needs to be more work for looking at studies for tendinopathy. Kentaro Onishi from Mayo, who was at University of Pittsburgh and was a fellow at Mayo Clinic, has put together a really nice systematic review of all the studies for tendinopathy for anyone that wants to look at it. And I think looking at all the studies for the different body parts, there are many randomized control studies, and most of them have shown good improvements. There are certain body parts that are more challenging, and getting the right diagnosis is critical, but overall, you'll see that PRP has been effective. So this is one algorithm of how PRP is used to the right. What I'll talk about is the way I talk about it with patients is PRP is effective for arthritis. It can last at least a year for treating arthritis, and it can be several years. For tendinopathy, I'll tell them that one injection can be a long-term treatment options for patients. And the algorithm to the right is just one option. I don't know if everyone can see it, but the way I look at a patient for knee arthritis, I see if they have mild to moderate arthritis, so I'll look at their Kelvin-Lorentz scale. I'll look at to see if they have any subchondral bone edema, if we do have an MRI. I'll look at their body weight, and then I'll think about what treatments are effective for them. And then usually, if they're a little bit older, I'll offer PRP plus hyaluronic acid for patients, and then reassess at 6 weeks and 3 months. At 6 weeks and 6 months, and see how they're doing. I won't go into too much detail, but I think there's some emerging treatments for stem cells, and the way we get stem cells are from 2 different areas. And they're not really called stem cells, they're called mesenchymal signaling cells, because we don't get a high enough concentration of them today. But the areas we get them are either from your bone marrow or from your fat, and those 2 areas are areas that have some cells that and other important properties that we think about for improving your pain and function. And so the studies I'll highlight, the first one up to the left was done at Rothman University. It was a double-blind prospective randomized control study, and it showed a significant improvement in pain and function and using SBF, which is not legal in the United States, but they use an enzyme to digest the adipose and improved patients' pain and function pretty substantially. The study below looked at a 3-year follow-up of microfragmented adipose and showed good improvement in pain and function. The next study, which was done at University of Southern California in LA, showed strong evidence for improvement in pain and function, and that stem cells were very safe for patients. And then one study that was done recently, about a few years ago, looked at patients over the age of 60, and they saw 2-year outcome of improvement. It was a multi-center international study and showed improvement in pain and function for patients Kellgren-Lawrence grade 2 to grade 4 for arthritis. This is a study that everyone should be aware about, and I think it highlights the challenges that we still need to solve for cell-based treatments, but it was done by Emory University and Kenneth Mountner, and it showed cell-based treatments versus cortisone, and they had 4 arms. They looked at umbilical cells, they looked at BMAC, they looked at adipose, and they looked at cortisone, and they showed that there was an equivalent of all 4 treatments, and they couldn't determine superiority. There's going to be some follow-up studies, but this was a very well done study by a very well reputable physician in the orthopedic and physiatry community. But going back to PRP, there's 2 consensus statements that I want everyone to know about. The first one was in 2020, the NBA came out with a consensus statement for their athletes supporting PRP for the treatment of knee arthritis and patellar tendonitis. And the American Academy of Orthopedic Surgery has produced a technical statement. It's a really well done document looking at many studies in support of PRP for improving pain and function for mild to moderate knee arthritis. What's really important, transitioning away from just looking at the evidence for these, is hearing patients' testimonials. And what I want you to pay attention to in this video, this is a patient who I did PRP for her elbow, is just hearing how her pain has improved over the course of several weeks. And I think these are the type of stories that every doctor is seeing with PRP. And I think, although not every person is a responder, if we identify the right patient, we identified the right condition to do it for, and we use the therapeutic dose of platelets with a proper rehab program, this is the expectations of some patients that I.
So this patient's 2 months after PRP for her elbow. She's been having pain for over 2 years now. Do you mind telling the doctor about how you're doing?
Sure. So I had the PRP procedure done 8 weeks ago. And at about the 6-week mark, I really started feeling improvement. The pain decreased from the touch and movement. And now at about 8 weeks, my pain level is about a 2 periodically after physical therapy. This is the best I've felt in 2 years since we've been trying to address the elbow tear and rotator cuff. So the elbow tear is the best I've felt in 2 years. So I'm amazed after 8 weeks how much my pain level went from an 8 or 9 to a 2, and it's intermittent, not consistent anymore. So this was the right thing for me. I'm so glad I was referred to.
So I think that story just talks about, as you can see, they're still gonna have some pain, but it's significantly improved than what it was. And at 6 weeks, for most patients, they can get back to activities. What I think is really important is using ultrasound to identify the injury, using the PRP, augmenting it with a proper rehab program, and getting them back to the activities in a thoughtful way. The next case I'll talk about is a male collegiate baseball player. And I think it's really interesting because it touches a lot of topics that I'm talking about, which is putting the whole package together. And you can see here, the first thing is getting the diagnosis right. So this patient had a small effusion, tenderness over the flexor pronator mass, tenderness over the medial epicondyle, had a little bit limited of range of motion. There was a positive moving valgus stress test on exam. And the initial diagnosis and plan for this patient was relative rest, brace with resting, tape them. Baseball players want to get back to activity, but trying to get them to have things calm down. Unfortunately, they didn't improve. So the next step we did was after the season, we did an ultrasound of their elbow. And as you can see in the picture to the left here, you can't see it, but the proximal, so left is proximal, right is distal, and left is the medial epicondyle, and right is the sublime tubercle of the ulna. And you can see that more black area or hypoechoic area is a low-grade partial tear of the ulnar collateral ligament. And when we stressed this person, we actually saw that there was a widening of the elbow joint, which tells me that the partial tear was causing the joint to open up a little bit. So we saw the injury under ultrasound. We got proper amount of platelets. I used ultrasound to deliver the injection to the proper place, and we put PRP 1 week later. And then we took that patient and we made sure we didn't just send them off into the wild. We had a very thoughtful rehab program and made sure that we braced them and transition them back to throwing over a course of 16 weeks. And what I think is really important here is PRP is a catalyst with rehab to really get patients back to activity. But this is not a quick fix. And I think that's something to make sure you explain to patients. And so you can see 6 weeks later, there wasn't any more gapping when we stressed them under ultrasound. And I think this is similar to what we see in some studies. There's been several studies that looked at treatment of partial tears, ulnar collateral ligament tears for PRP, showing 88% of patients return to activity, but it takes at least 12 to 16 weeks of rehab. And then there was another case series published in the American Journal of Orthopedics showing it takes a while for high-level throwers to get back to activity, but PRP can help improve patients for getting back to activity that they want to return to. And this was a study showing that the average return to play was 36 days, but it was for hockey players. So I think what's really important is understanding the activity that patients want to get back to, whether it's pickleball or it's for hockey or baseball. It's really important to take that into consideration for a rehab program. And then what I want to talk about next is a case example of why ultrasound is really important for the diagnosis to make sure you can get the platelets to the proper area. So if you can see here, left is this is the Achilles tendon, left is distal, right is proximal, superior is at the top. As you can see here, there's a big bone spur to the left. And then what I want you to pay attention to is one of the things I'll do is I'll passively dorsiflex and plantar flex. And you can see that this patient had a partial tear deep, and they also had diffuse tendinopathy. So this is a very complicated patient where we're trying to really think about where is the tear and where is the proper place to put PRP. And from my experience, it's really important to understand who does well and who doesn't well. Diffuse Achilles tendinopathy, which means the whole tendon is thick, is is a lot more challenging to treat than someone who has focal Achilles partial tear. And you can see it's the picture to the left, that black area is a deep partial tear. And so that person will do a little bit better where we can put PRP, maybe protein concentrate in a confined area to help them with healing with a rehab program versus someone who has diffuse Achilles tendinopathy. And, you know, I'm hitting this to death, but what's really important is making sure for this Achilles tendon patient and for any patient that we have a thoughtful program. And so that includes tissue protection. So most patients are non-weight bearing for 4 days for their lower extremity. They'll be in a sling for their upper extremity. Then we think about early tissue healing over the course of the next 6 weeks, and then collagen strengthening over the next 3 months. And I published a chapter with Kenneth Mountainer from Emory and Walter Sussman, where we really try to map out the how PRP works and how we can think of a thoughtful rehab program over the course of those 12 weeks. And we've published it for each condition. We have lots of rehab protocols. And what I think is really important is thinking about the whole package when you're thinking about PRP for a patient. So if we can put the whole package together, we can get great results. And these are the patients that one of the things, I work in a very big orthopedic practice. I definitely have some people who don't believe that PRP can help. And so what I've been doing is trying to put a registry together, identify the conditions that I think will have the best chance of improvement, and then showing a lot of my partners in the practice, what are the outcomes that we can have. And so when we'll put the whole package together, these are some of the conditions that I think are appropriate. And these are some of the results that I've had over the last year. So we saw that there was, for shoulder, low grade, partial, articular sided or interstitial tears in the supraspinatus, mild to moderate shoulder arthritis, partial tears, tendinopathy of tennis elbow and golfer's elbow, partial tears of the proximal portion of the UCL, mild to moderate CMC arthritis in the thumb. For the hip, a small labral tear with not significant FAI or not significant arthritis, usually tonus 2 or less. Hamstring tendinopathy, glute minimus and medius tendinopathy, mild to moderate Kelvin-Lawrence knee arthritis, no subchondral bone edema, no malalignment, and a BMI 35 or less. Patellar and quad tendinopathy, mid-portion focal Achilles tendinopathy, mild to moderate ankle arthritis, and plantar fasciosis. And so, if you ever come to my clinic, you'll see that we're religious about trying to get patients to complete their outcome measures, and my medical assistant follows up with patients not only at the 6-week mark, but we'll call them as we're trying to do some research for patients and be able to talk with them about what's the expectation that they'll get based off of other patients that came before them. And so of 130 people, I had a 96% success rate. I did have 4 failures, and I had patients, on average, the pain, we use PROMIS scores, and their pain interference improved 10 points for their pain and 6 points for their function. Both were achieving above the minimal clinical important difference. And someone who has an amazing outcome in arthroscopic meniscal surgery has a 6.5 points of function. So on average, the patients had an amazing outcome that was comparable to a knee surgery in the cohort that I had for my registry. I just have a few slides that I always like to talk about that I think is really important and is near and dear to my heart. It's really important to use ultrasound when you're thinking about these injections, because it's important to have a proper diagnosis and to deliver the medication to the proper location. And this was a study done out of Penn State University, and they looked at every single injection in the body, and they saw that most of the injections, they published the literature, which ones were more accurate and more effective, and most of them were more accurate and more effective with ultrasound guidance. And where I trained at Mayo Clinic, there was a landmark study that was done, and they just looked at hyaluronic acid, and they saw ultrasound-guided HA versus landmark-guided injections, and they followed these patients out for 12 years. And we saw that if we did the injection under ultrasound, we delayed the need for a knee replacement by several years compared to the landmark guiding injection. So a journey is 1,000 miles and begins with a single step. Look forward to hearing your guys' questions and answer any thoughts about regenerative medicine and outcomes that I've seen in my clinic. Thank you, guys.
Thank you, Dr. Gruner, for sharing your expertise. Greatly appreciated. We have had a number of questions that have come in. I still want to encourage you all to use the Q&A section, the chat portion of that you can throw questions in there. But I think where we're going to start is we know that their education is extremely important as far as that initial patient consult. How much information are you providing for your patients to educate them on their treatment options to include PRP?
Yeah, so every patient that I'll see in my clinic, they'll get a regenerative medicine packet that explains everything in easy language. I also will have studies that I'll have them go to for different things so they can read about this. Every single person gets a rehab protocol, and then if they decide that they want to be involved in a regenerative medicine procedure, they get placed in the regenerative medicine registry that we have.
Okay.
Every patient gets counseled on the pre-procedure information, which includes no NSAIDs for me for 2 weeks before and for a month after. And then we also talk about the nutrition and rehab protocol to optimize them for a healthy outcome.
Okay, great. We did have someone that did send something in as far as registry questions. So what's the name of the registry that you use? Is it private? Is it something that they can have access to?
Yeah, so there's many registries out there. I won't go into too much detail, but so the company I have has outcomes that we track. The patient IQ is a registry that our orthopedic group uses. Autologous is a registry that offers really is bringing together a regenerative medicine community and tracking patient-reported outcomes.
Okay, excellent. Is there a certain age or other factors that may steer you away from recommending PRP as a treatment option, I guess, for the patients that are coming in to consult?
Yeah, if you can see from that one slide, as you get older, platelets do decrease in age. So I think it's really one of the things that we're gonna have to think about is how can we get a larger amount of platelets as you get older in life? I think is an important factor. And then are these platelets viable? I think that there still needs to be some work there. That is something that I'll talk to patients about if they ask.
Okay, great. And when you look at the decision points as far as different treatment options, when you're weighing MFAT versus PRP or maybe bone marrow, what makes you decide whenever you have a middle-aged patient, say for knee osteoarthritis, how do you know which route to go?
So thanks to my training at Mayo Clinic, I really believe in shared decision-making. So the way I explain it to patients is there's different treatment options that we can do that help you heal. We can do physical therapy, we can brace you, we can consider injections, and we can consider surgery. And some of the injections that we can consider include cortisone, platelet-rich plasma, bone marrow aspirate, and adipose. And then I'll kind of work with them to understand what they're interested in hearing about. And then based off of that, I'll dive deeper.
Okay, fantastic. I know that you had said, this kind of aligns with a question that has come in, but if you're seeing success, a couple of years out, obviously within studies, it's showing at least great results up to a year. But do you ever find that there's been a time where you feel that multiple PRP injections is going to be a benefit to the patient? How many times would you consider actually re-injecting the PRP?
Yeah, I think this is the question we're still trying to figure out. I would say there's some doctors that believe the 3 injections, others want 1. Currently, I do 1 in my practice, but I think that's something that I'm always trying to look at the literature and trying to weigh, think about the benefits and the risk of doing multiple procedures. Part of my interest outside of regenerative medicine is value-based healthcare. So I'm always thinking about what is the value that I can help for treating a patient. I grew up in Bethesda, Maryland. I want to make sure that I'm a reputable physician and make sure I can get the best outcome for my patients, and also make sure that if they are going to pay $1,000, or an injection, that they know that that outcome can last them a long period of time.
Sure, absolutely. Have you seen any studies showing evidence of radiographic improvement with orthobiologics, which modality and which structures?
I have not seen that to date. That's currently something that I'm interested. There is a study that just came out showing improvement in the signal on an MRI. This one just came out, but that signal was just looking at a T2 fluid edema that was in the subchondral bone. It didn't look at the actual joint space improvement, which I think is A, very hard to measure, and B, not something I would tell my patients.
Sure, okay. Next question is still aligning with current studies that we have available. So have you seen any studies investigating the use of PRP in insertional Achilles tendonopathy with calcaneal heel spur? There's a second part to the question. Have these injections resulted in clinically significant improvements and or functional gains that are superior to current standard of care?
There's a lot there.
Yeah, I know there is. I know there is.
So 80% of people who have Achilles tendinopathy, 80% is mid portion because there's a lack of blood supply, 2.5 centimeters proximal to the Achilles insertion. And then 20% is insertional. Mid portion does better than insertional. So insertional can be really hard. But some people have a Haglund's deformity, which is an extra bone there, piece of bone there. And some people have an esophyte or a calcification there. And so it can be really hard. Sometimes you have to remove those calcifications, and that's where I'll consider 10x, and then think about PRP if there's a partial tear that is focal. But it can be a real challenge. But what's really important is booting them afterwards, having them on crutches for a period of time, and then making sure they have a progressive program. For my Achilles tendon rehab programs, I'll always have patients make sure they get back to a certain amount of calf raises, and there's the calf raises that have been defined for your age, your gender, that you should be able to do so you can withstand the load and tolerance so you can get back to the activities that you do. And so that's what I mean, like, it's not just injecting it and forgetting it, it's putting together the whole process.
Yeah, absolutely. One thing that I think we all hear when working with providers that really want to get into the regenerative medicine space, and something that they might not be as comfortable with, is ultrasound. And we know the importance of ultrasound injections. So do you have any recommendations for ultrasound courses to assist sports med diagnoses and treatment?
Yeah, so I teach a lot for the American, both my medical society, the national courses, which are the AAP course, the AMSSM course. I teach at both those courses. I also teach expert education. Gulf Coast is another good course down here in Florida. And then there's definitely several courses, but it's really important that if you really want to get good at regenerative medicine, it's really important getting a good diagnosis, and that requires a thoughtful history, a thoughtful physical exam, and also using ultrasound to diagnose and treat the injury.
Yeah. I think another thing then goes along with protocols, treatment, starting dose. I think you might have kind of touched on this, but when you're looking at your initial blood draw, what's most effective, what's kind of what your starting dose that or blood draw that you would start with?
So a blood draw, I want at least 60 cc's, and the goal is to have at least 7 to 10 times the concentration of platelets. That's the goal that I shoot for.
Okay. Have you, again, along those same lines, have you tried other types of systems that maybe it could have been a long time ago that haven't offered these types of concentrations? Do you see them a lot? Do you see a lot of people that might be using these types of systems out in the field? I think, the question came in that, again, education, as far as that starting dose, what's your experience? What have you seen with different types of PRP systems?
Yeah, I think there's only a few systems on the market that have 60 cc's of blood and really get a high quantity of platelets to have an appropriate treatment, which I think you can see from that study is important. And there are definitely a lot of studies that have been done in reputable journals, New England Journal of Medicine, that have shown limited benefit of PRP. But if you look at that, they're doing 2 to 3 times the concentration of platelets. And I think if you hear anything today, the concentration is important. You're not going to give someone Coumadin that is subtherapeutic. You're not going to give someone ibuprofen that's subtherapeutic. You want to think about an appropriate amount of platelets to have an adequate response.
Yeah, absolutely. So when you're looking at the quantity of PRP, so volume, the amount of injectate, how much are you typically injecting? And are you solely injecting into the tendon, ligament, or laying something around the area as well?
Yeah, this is I would say a lot of doctors have a lot of different strategies for this. For the joints, I'm for the most part doing it into the joint. If there's not like a meniscus injury that I'm really concerned about, but it's more for the arthritis. For a tendon injury, I really think and this is very important. Why diagnostic ultrasound is really important. As you could see in some of the pictures, it's important to get the length and the width of the tendon. I know you were with me in clinic before, and that is critical. Because if you just do PRP in one injection spot, you're not going to get it to all the areas. And so the tenotomy and making sure you get all around the tendon edges plus the PRP is really important.
Okay, and in some of those types of circumstances, have you tried platelet-rich fibrin combined or making PRP into platelet-rich fibrin, kind of editing that question for scaffolding with partial tears?
I have, and I think that is something that's really, really interesting. I don't think there's enough studies out there for us to jump on it right yet, but I do think it's really interesting. And I think the idea of having platelets plus a scaffold for a low-grade partial tear is something that I've been interested in. My partners in my practice also think that's an interesting opportunity for regenerative medicine.
This one's kind of a loaded one, like some of the other ones. I'll do it in portions here. Yes, when utilizing stem cells, how can you be sure that injecting them into a relatively avascular joint is going to be able to have adequate micronutrients for growth?
You can't. I think that's the short answer. We don't know these things yet. And it still needs to be studied.
Okay. And again, extending on that, is there a way that we can know that the stem cells differentiate into the appropriate cell types and are even going to be able to attach to the tissue in the appropriate location, especially highly mobile weight-bearing joints such as the knee?
We don't know that yet.
Okay. What do you tell your patients? This kind of goes back to the education portion. What do you tell them when they only want to do a treatment option that only insurance covers? How do you kind of approach that to give them the best education as far as what's going to benefit them the best?
Well, I will talk to them about the treatments, and I'll provide all the treatments. If they're insistent about only insurance-based treatments, unfortunately, it's cortisone or hyaluronic acid. Hyaluronic acid only for the knee. But I'll also mention to them, the studies and ask them that if, they're interested, here's some studies that you could read and some areas that you can go online and do a Google search for yourself.
Have you used PRP for fractures that are notorious non-union, such as a Jones fracture?
I have not done that. I think that can be really, really hard. And Jones fracture, our foot and ankle surgeon will say, is one of the more challenging fractures to heal. So I have not done that.
Whenever you have patients that are on anticoagulants, do you stop anticoagulant use, or is there a certain population that you can't and you have maintained their anticoagulation therapy? How do you approach those patients?
I think that's a really challenging subject. I think you have to talk about the risk and the benefits. If they're on anticoagulation, it's important to look at their TRAB2 score, see their increased risk of clotting. And then I also think that we don't have a strong evidence to stop the blood thinners for patients that I can really, that the risk might outweigh the benefit there. So it's not something that I really put pressure on. And the way I kind of describe it to patients is there's small potatoes and there's big potatoes. And I think that's more of a small potato for us right now. The NSAIDs is something I feel pretty confident about. And I also say the NSAIDs aren't the best for your stomach or your kidneys. So maybe give your kidneys, your stomach, and your heart a rest. So while we're treating some of this.
At what point do you feel that arthritis is too severe for PRP to be a viable treatment option and instead recommend surgery?
Yeah, so I mean, most of the studies have shown Kelvin-Lawrence 1 to 3 arthritis. You know, I'll usually say 80 to 90% of people will be a responder. For the non-responders, I have some other things that I'll try to do to help them out. But once it gets to more severe arthritis, I really say it becomes a coin flip. And it's an important shared discussion making with the patient and really not selling the expectation, because you know, you don't want someone to be really dissatisfied with this, especially if you're trying to build it up a reputable reputation in the community. And so I'll talk about, you know, that it might be a coin flip. And if it's a coin flip, it's up to you about what you want to do. My recommendation would be this, and depending on the situation and the severity of how bad this severe arthritis is, we'll talk about options for the patient.
You had pointed out in your presentation, I guess, different pathologies that respond very well to PRP. Have you found areas to be more challenging, or any certain areas to be more challenging that you would shy away a little bit more from it? And how do you talk to your patients about that?
I think the Achilles tendinopathy can be challenging because of what I showed you today. So like really good diagnostic ultrasound. People that are willing to follow the rehab protocol, I think, is really important. Patella tendinopathy does very well. Glute tendinopathy does well. I've had success with hamstring tendinopathy. Tennis elbow probably does the best of the tendon treatments. Most of the studies have been on for knee arthritis. I've had good success for hip arthritis, but that can be challenging sometimes. The one area that can be hard is shoulders. And I think you really have to know what you're looking at for a shoulder, because the biceps tendon is 2 millimeters from the supraspinatus tendon. And you don't know if they have a cable injury or if that tendon is really unstable or if it's a partial tear there. So I think that one can be tricky, and that's why I think the studies have been mixed in some ways.
Okay, so if you do have a patient that has had a corticosteroid injection, how long are you waiting before you would actually initiate a PRP injection or bone marrow adipose?
This will differ for people. I'll wait a month.
If you do have patients that are excited to try PRP, but when they find out that it's out of pocket, they cash pay, they decline, how do you discuss that with the patient, or you know, to talk about the value, obviously, that PRP can offer?
Yeah, I mean, the way I'll explain is, you know, you coming into the clinic, especially if they're commercial insurance, you coming into the clinic, you're going to have at least a copay for at least 3 or 4 visits. You know, hopefully you're not doing cortisone more than 3 times in a year. And that's going to run you about $900. And if I can do 1 injection and a PRP, that's something that might be a better opportunity for you than coming back and seeing me 3 or 4 times in the clinic.
When again, going back to areas that you've had success or that you've seen success with these types of injections, have you utilized it in the sacroiliac joint? And if you have, what kind of success are you seeing?
I have, very limited. It's not I don't think I can comment on it enough.
Okay, all right. I think that's about all the time that we have for questions this evening. We didn't want to take up too much of your time and keep it within the hour time frame. So we do want to thank you, Dr. Gruner. Wanted to extend a thank you to all the participants for making tonight's event a success. We appreciate your time. Certainly hope you found this session to be valuable. We are going to send a recap to you of tonight's session with studies presented, with links, so keep an eye out for that, as well as future webinars that we will be hosting. Thank you again, Dr. Gruner. We appreciate you being here, especially with our live audience today and everyone out there. So with that said, everybody have a great evening.
Thank you.